Hi everyone, it is Alexey Lebov. In this video, we will discuss next clinical case scenario. A 45-year-old woman came to the clinic. She has never smoked, but mentioned that currently is working in pet veterinary clinic and is experiencing breathlessness and cough after contact with pets. During physical examination, she appeared unworried at rest, speaking in complete sentences with a respiratory rate of 14 per minute. Blood pressure 123/84 millimeters of mercury. Oxygen saturation of 99%. Her weight is 92 kg and her height is 176 centimeters. Auscultation of the chest shown bilateral expiratory polyphonic wheezes with vesicular breath sound. There were no other abnormal findings on examination. Physician decided to perform pulmonary function testing. Patient was asked to inspire maximally and after exhale as hard as possible into spirometer. The baseline volume time curve represented by red color. Following baseline testing, physician gave a medication to the patient and asked to repeat maneuver again. Post-drug administration curve represented by green color. Stimulation of which of the following receptors are most likely responsible for the changes represented on the diagram? A. Beta-2 adrenergic receptors. B. Beta-1 adrenergic receptors. C. Muscarinic M3 cholinergic receptors. D. Muscarinic M2 cholinergic receptors. E. Alpha-1 adrenergic receptors. And F. Alpha-2 adrenergic receptors. Pause the video and try to answer. So, before answering the question, we should understand representative curves. These curves were obtained during spirometry after maximal inspiration and forced rapid and full expiration into the spirometer. So this curve represents force maneuvers. Are you able to interpret these curves? If so, most likely that it was easy enough for you to find a correct answer. If you are experiencing some difficulties with interpretation, let's do it together. Spirometry is one of the most common pulmonary function tests. It measures the amount and/or speed of air that can be inhaled and exhaled. Spirometry is helpful in assessing breathing patterns that identify conditions such as asthma, pulmonary fibrosis, cystic fibrosis, and COPD. So, let's talk a little bit about spirometry and spirogram. Spirogram usually presented as a chart. On y-axis we have volume of air in milliliters or in liters usually, and x-axis represents time. At the beginning of spirometry, physician asks patient to breathe normally as in daily life. Let's say the patient started breathing from volume of air in the lungs equal to 3 liters. So the volume of air we inspire and expire during shallow or normal quiet breathing is called tidal volume. In average, it is 500 milliliters. After normal, quiet, shallow inspiration, physician asks the patient to inspire maximum additional amount of air. In average, this additional volume of air that we are able to inspire after shallow inspiration is equal to 3000 milliliters or 3 liters of air. And as a result, we have around 6.5 liters at the top of our spirogram. So, the maximum amount of additional air that can be inspired from the end of a normal inspiration is called inspiratory reserve volume, or IRV for short. After this maneuver, patient continues to breathe normally. After expiring a tidal volume, we are capable to exhale additional volume of air. So let's say from 3 liters we are reducing lung volume to 1.2 liters by exhaling additional volume of air. And this volume is called expiratory reserve volume, or ERV. In other words, expiratory reserve volume is the maximum volume of additional air that can be expired from the end of normal expiration. In average, it is equal to 1100 milliliters of air, and based on our spirogram, it is 1.8 liters. Now let's talk about forced maneuvers. During forced maneuver, patient is asked to inspire maximally and after exhale as hard as possible into spirometer, just as was previously described in our clinical vignette. And after this maneuver, patient continues to breathe normally. Let's analyze obtained curve. The difference between the maximum point and the lowest point at the curve is called forced vital capacity, or FVC for short. The definition of forced vital capacity is almost the same as the definition of vital capacity. It is the volume of air expelled from the lungs during a maximum expiration, starting after maximum inspiration. The only difference is that forced maneuver should be made as hard as possible. So we are trying to limit time for this maneuver for the patient during forced maneuver. And if we will find 0 point when patient has started exhalation after maximum expiration, and will count 1 second from this point, then we will have forced expiratory volume during the first second, or FEV1 for short. Residual volume of air is the volume of air left in the lungs after a maximum forced expiration. It corresponds to around 1.2 liters of air. And residual volume is the only volume of lungs which cannot be measured directly with spirometer. Vital capacity, or VC for short, is the volume of air expelled from the lungs during a maximum exhalation, starting after maximal inspiration. I am indicated it by blue color on our spirogram. The total volume of air in the lungs after a maximal expiratory effort corresponds to total lung capacity, or TLC for short. Inspiratory capacity is the maximum volume of air that can be inspired after an expiratory position. So basically, inspiratory capacity, it is the tidal volume plus inspiratory reserve volume. Functional residual capacity, or FRC for short, is the volume of air at the end of a normal tidal expiration, and it corresponds to equilibrium state of the respiratory system. Let's summarize. We have 5 volumes on spirogram and 5 capacities. Just keep in mind that capacity includes 2 or more volumes. The volumes are tidal volume, inspiratory reserve volume, expiratory reserve volume, residual volume, and forced expiratory volume during first second. The capacities are vital capacity, total lung capacity, inspiratory capacity, functional residual capacity, and forced vital capacity. Now, let's calculate forced expiratory volume during the first second, or FEV1, and FVC, or forced vital capacity. FVC starts from the point of 6.5 liters, and patient exhales to the point of 1.2 liters. The difference between them will be the forced vital capacity. So 6.5 liters minus 1.2 liters equals 5.3 liters. FEV1 also starts from the same point, 6.5 liters, And let's assume that during first second, patient exhales some volume of air to the point of, let's say, 2 liters, like on our spirogram. Then FEV1 will be 6.5 liters minus 2 liters, that equals 4.5 liters. In clinical practice, it is important to calculate FEV1 to FVC ratio. The FEV1 to FVC ratio is the ratio of the forced expiratory volume in the first second to the forced vital capacity of the lungs, and the normal value for this ratio is around 0.8. It means that 80% of air should be exhaled during the first second. Values less than 0.8 are suggestive of airflow limitation with an obstructive pattern. Let's calculate this ratio for our obtained values. It will be 4.5 liters over 5.3 liters. That equals 0.85. Or 85% of air was exhaled during the first second, which is normal based on the obtained spirogram. Now let's go back to our vignette and analyze the curves we have. As it was mentioned before, the red curve represents baseline curve before drug administration, and the green curve represents changes after drug administration. Let's focus on the red curve first. The zero time corresponds to 1 second on the x-axis, and 1 second will be till 2 on the x-axis. So this time is a 1 second, and it corresponds to the volume of 1.5 liters. We are starting from 5.5 liters. It is the maximal volume of air patient inhaled, and this is the volume of air patient exhaled during first second, or FEV1. So for baseline curve, FEV1 will be 5.5 liters minus 1.5 liters is equal to 4 liters. Now let's calculate forced vital capacity, or FVC. The FVC will be the difference between 5.5 liters and this red point at the bottom of the curve. This point, as you can see, corresponds to the volume of 1 liter. So this will be FVC. And let's calculate it. 5.5 liters minus 1 liter equals 4.5 liters. FEV1 to FVC ratio will be 5 over 4.5 equals 0.89, or 89% of air was exhaled during the first second. And this matches with clinical picture of the patient. But after that, physician gave to the patient some medication, and new curve was registered. The green one, curve obtained after drug administration. Let's do the same calculations for the green curve. At this point, we have time of 1 second, and this will be a FEV1 for the green curve. So FEV1 will be 5.5 liters minus 3.5 liters equals 2 liters. Now let's calculate FVC. We'll go to this point at the green curve, and this difference is FVC. Basically, we have 5.5 liters minus volume at this green point, minus 2.5. And this equals to 3 liters. What about FEV1 to FVC ratio? It will be equal to over 3 liters, or 0.66, or 66%. So what is conclusion? We have FEV1 to FVC ratio, or 89%, with baseline curve versus 66% after drug administration. We can conclude that drug caused bronchoconstriction. The question is asking, stimulation of which of the following receptors are most likely responsible for the changes represented on the diagram. So, stimulation of which of the following receptors caused bronchoconstriction? Do you remember receptors in the lungs? We have two types of receptors, M3 and beta 2. Stimulation of M3 receptors causes bronchoconstriction. Blockade of beta 2 receptors also causes bronchoconstriction. Stimulation of beta 2 receptors causes bronchodilation, and blockade of M3 receptors causes bronchodilation too. So, we say that administered drug caused bronchoconstriction, and we should be focused either on M3 receptors or beta 2 receptors. But as we are talking about stimulation, the correct answer is M3 receptors only. What kind of medication she had? Most likely, it was a methacholine, cholinergic agonist. Methacholine challenge test, also known as a bronchoprovocation test, is performed to evaluate how reactive or responsive patients' lungs are to environmental allergens. It can help to evaluate symptoms suggestive of asthma, such cough, chest tightness, and shortness of breath, and help to diagnose asthma, as in our case. During the test, patient will be asked to inhale doses of methacholine, a drug that can cause narrowing of the airways, similar to those in asthma. A breathing test will be repeated after each dose of methacholine to measure the degree of narrowing or constriction of the airways. The test starts with a very small dose of methacholine, and depending on patient's response, the doses will be increased until either patient experiences 20% drop in breathing ability, or you reach a maximal dose with no change in your patient's lung function. I hope you enjoyed this video. Put your likes and subscribe to my channel. See you!